Thank you, Reinhard, for a very rich presentation. We have some 20 minutes left for questions and for discussion, so I would like to start by asking the audience whether there are any questions or points for discussion related either to the first presentation that was focusing on between country differences and health policy, or the second one focusing on inequalities within countries and healthcare policies. Who would like to open the discussion? Yes, please. A microphone will be coming to you.
Arnoldas Rugutis, European Primary Healthcare Forum and also Klaipėda University. I want more to focus on second presentation where we talk about inequalities and healthcare system. In fact, we're talking about unmet needs, but there was a lot of emphasis about accessibility to healthcare, to specialized care, to healthcare, timely addressing screenings and so on. But when we look to these different socio-economic classes, sometimes these determinants and determinants of health is lies in behavioral factors. It lies in risky behavior and so on, which lead to differences in health status. So my question is about should we look more deeper and find some, for example, factors of more community-oriented primary health care, where you have more interventions in addressing risk factors in risky behavior and so, not only talking about accessibility to healthcare, because accessibility to healthcare, as we know also from Barbara Starfield studies and so on, sometimes really creates a high consumption, and this consumption do not lead to best outcomes. Sometimes it's specialist supply, and so leads to waste of money and not really good outcomes. So I want to reflection to this my question.
Thank you. That's a very good question, I think. Well, primarily directed towards Reinhard.
Does it work? Do I have to do anything here? I think we have to see the two presentations together. When you look at my framework, when I said, okay, there is need, of course the need will be determined how high the need is by health policies also in that country. If there is better health policy with all the factors which Johan said, then of course then the need and possibly the variation in need, but I mean that needs to be seen. For example, let's take an easy one. When we address the need to get surgical treatment after a road traffic accident in a country which is really enforcing seat belts, we have lower need, and so then the filter to access we have less problems there. Whether really is the seat belt enforcement will affect all socioeconomic groups the same remains to be seen. So we see that even the health policy measures, alcohol, tobacco, and so on, we still see different health care need because the result of health policies is not the same in all socioeconomic groups. So I think we need to reflect that, yes, in health policies the same works. When we work on the average, overall need goes down, but we still will have groups which need for health care.
Yeah, wouldn't you think that the same principle that you are advocating for health care should also apply to health policy?
Of course.
Yeah,
I mean, that would be, if you take this inverse care law and apply it to health policies, that would be as if the police would only patrol for seatbelt wearing in the better off areas and think, okay, the people in the disadvantaged areas, they will die anyway, so whether they wear a seatbelt doesn't matter. And it's a bit like this when we allow that all the physicians go to the good areas and no physician goes to the bad areas.
Thank you. There's another question over there.
Yes, thank you, Reed Ridder from Belgium. Thank you very much for the two excellent presentations. I have just one question. One element didn't come up in the analysis, which is the educational level of the families, which is one important aspect of differences in social classes. And as far as I know, the education is a very, very important factor, because inequities in health start already from very early childhood, depending on the capacities of families to deal with health opportunities. So do you have any comment on that?
Well, I mean, you saw that. I mean, when we take at least, when we try to classify people into socio-economic groups based on what we know about them, income, education, employment status, we see the strongest relation in income. But you saw that education was shortly behind it, and of course they are highly correlated. So yes, it's important when we then measure inequities, and especially when we come to area measures. I mean, when we look at individuals, it's one thing, but when we talk about healthcare, we are also interested, in which are deprived areas where you have generally higher need for people, that correlates better to the average income in that area than to the average education in that area, even though they are also highly correlated. And of course, yes, I mean, you are right. It's an important factor, but when we come to healthcare and healthcare needs, it's quite late in the course of our actions.
Let me add one comment. It's indeed true that education, income, occupational class, and other indicators of socioeconomic position have their independent effects on healthcare use, on health outcomes. But the other question that your point raises is whether education is also an entry point for tackling health inequalities. I think that's also what you meant to ask. And I think the answer is clearly yes. Raising education levels and increasing access to good quality education for people from low socioeconomic backgrounds, I think is a very there are some ongoing programs, particularly in the US and in the United Kingdom, where good quality preschool education is offered to children from lower social class backgrounds, not only to improve their educational performance outcomes, but also to improve their health behaviors and later health outcomes. And I think that's a quite promising approach to tackle health inequalities. There are several other questions. I see 1, 2, 3, 4. Let's try to do these 4, and then we will probably have to break up.
Žilvinas Padaiga, Lithuanian University of Health Sciences, Kaunas. It seems that health inequalities are not created by healthcare sector. Perhaps we agree with this, that it's not us who created health inequalities. And yet we are trying to do something about them. My feeling is that we are behaving a little bit in a dangerous way, because other sectors who in fact are responsible for these health inequalities would really encourage us and say, yeah, yes, go for it, we like it, do this, make health policies, measure it, more research, and in fact we depend heavily on other sectors. That's why when in Lithuania we were creating health policy, we looked at the Swedish health policy kind of domains. The first 3 domains are inclusion, participation of the society, social, economic favorable conditions, favorable conditions in childhood, and only then goes health promotion and so on. What is your opinion about this rather isolated movements in health sectors in many countries to decrease health inequalities, especially when we are not linked with other sectors? And this is quite a case in Lithuania.
Thank you for your question. You started by making a statement that the healthcare system does not produce health inequalities. I wonder whether we agree to that. Reinhard?
Well, I don't. Of course, I mean, when it depends on what level you argue. I mean, you could start in my framework when we're talking about need. We would say yes, it's somebody else who has produced the inequities in need. But the filter, and I think I was able to show you, the filter does not work equitably. So more people with higher needs fall somewhere out through the filter, and so that the result of what we, so it's not only that we are not treating the ones with more need somehow better, so are not only not narrowing the gap, but healthcare is actually widening the gap in the end result.
Yeah, so I also think that healthcare is actually at least sometimes widening the gap, and the same is true for health policy. So we know that many measures in the field of tobacco control, for example, they tend to widen inequalities in smoking because they are more effective among people with a higher socioeconomic position. So in that sense, I think we really have a responsibility within the healthcare system or within the health system more generally to eliminate those elements that actually widen health inequalities. At the same time, I also agree that most of the causes of health inequalities lie outside the health system, and there I think our responsibility is to try to engage policymakers in other areas to help us all together to reduce health inequalities. I hope that that's a sufficient answer for the moment, because we have 3 other questions. Yeah, I'm doing all 3 that are still left. Barbara, questions? Yeah. Please wait for a microphone. We can't hear you. We'll take the 3 questions at once and then see who will answer them.
Okay, Barbara Kestjens, European Commission. I was wondering, we spoke about education, but could you speak to the importance or the role you think health literacy, which is slightly different from health education, might play in helping reduce issues of inequalities and access to healthcare?
Health literacy. Then the lady in the yellow jacket. Please take a microphone, I can't hear you.
Dimitrova from Bulgaria. My question was more in the same direction related to health literacy, and it is to Mr. Busse. You mentioned in your presentation a study which is demonstrating a widening of health inequalities due to screening programs which were offered for free, I mean covered more or less. Would you mind to elaborate more on the reasons found by the study for like poorer people not taking the advantage of using the services provided? I assume that one of the issues, as we all have discussed, is the low level of education and the low health literacy level, but would you mind to give more explanation, at least from the study, on this issue? Thank you.
Thank you. And then the 3rd question, the lady in the purple jacket.
Yes, thanks very much, Sian Jones from the European Anti-Poverty Network. I mean, thanks very much for the presentations. I think you make a very convincing case about the importance of a universal healthcare system, which I hope you say should be free at the point of entry, because obviously that's a crucial issue if you're really going to talk about inequities. What I just would like to draw a point is that you show the evidence very strongly that the countries that do better have universal coverage. But of course, those countries not only have universal coverage in healthcare, they have universal social protection systems that provide the whole package. So I think it's really crucial that when you're looking at solutions, you make that link, because otherwise I think it's rather misleading to think that you can only solve this through health policy alone. Because clearly what is key, not going so far as to say redistribute everything, is guaranteeing an adequate income. Ensuring adequate access to key services, not just healthcare, but education and other services. And that's what your whole package of social protection does. So I just wondered if you'd looked at those correlations.
Thank you. So there are 2 questions on health literacy, one on the total social and welfare package. Reinhard.
Well, just briefly, I mean, starting with the last one, access to all these other things, I would think that we have a similar filter in access to other services. So we can have a law which says, you know, you're entitled to go to kindergarten, school, meals on wheels, or whatever. But of course, it will also depend where you live, where the better schools are, and so on. So we have similar, if not the same, problems in the other sectors. And I hope, I'm a healthcare researcher, I hope that we have school care researchers who address the same issues for education. For example, I'm with the free at the point of service. I mean, what is free? You know, free includes from the standpoint of the patient also travel costs, for example, and so the actual cost sharing when you reach the hospital and they ask for €5, that might be much less than what the people have already paid to get there. So an unequal distribution of hospitals, for example, where people from poorer areas have to travel further, is probably a larger concern than €5 cost sharing in the hospital. So we have to take the overall viewpoint. I mentioned here that the caps on cost sharing are of course important. I mean, if you pay twice a year €5, even the poorer people will not go bankrupt with that. But if they're chronically ill, it's a problem. With the health literacy, and I think we already see the problem here. I mean, that it is hopefully a virtuous circle, but it can also be a vicious circle. I mean, those people who are better off, they are more health literate, they take up, and you're right, they take up the screening more often because they understand the relevance. And we need, so I think it's all well-meaning that we say we need to improve the health literacy. But if we offer health literacy programs and only the ones who are already have health literate go there, and the ones who are completely health illiterate don't go there, then of course afterwards we have more inequities, and we have to think about these things, I think, before we implement such a program, that they do not increase inequities.
Thank you. I think it's time for our coffee break. Let me end by concluding that we had, I think, an engaging session. I hope you enjoyed it and agree to perhaps the general conclusion, that is that inequities between countries and within countries should be at the center of health and healthcare policy. Thank you.